back pain and spine degeneration. When we speak about the incidence of back pain, it's very common complaint of many patients. 70 to actually to 100% of lifetime incidence, meaning at least once in the person lifetime will have some sort of back pain. The point prevalence, maybe recurrence of that could be up to 17%. The natural history of back pain, when we talk about back pain, there are many types, types depending mainly on the etiology. But when we talk about it in general, regardless of the etiology, almost 50% of patients the pain will go away within a week. This kind of pain most likely is caused by muscle spasm or overworking the muscle, and the acute muscular pain that will last for 1 week might be very severe at the beginning, but patient within a week, 50% of patients within a week will have a relief. 90% of cases, the rest or the other 50%, 90% of those would settle within 3 months. These are called subacute back pain, and will most likely settle within 3 months. Chronic low back pain can progress or develop in 5% of the population. And this chronic low back pain can be very devastating to many patients, especially if the etiology is unknown, which is called non-specific back pain, meaning that there is no true pathology on the MRI or the X-ray, but the patient continues to have significant disabling back pain, and treating that condition could take multiple specialists and a long time, and might not be cured eventually. Episodes of back pain reduces in both frequency and severity with maintenance of good core stability and general fitness. So some people would have recurrent episodes of back pain. These recurrent episodes of back pain most likely would be habitual, overworking the muscle in some way. So having, even if there is some degeneration or arthritis in the back or in the disc, keeping good core muscle, strength of the core muscle and the flexibility would definitely decrease the frequency and the intensity of the episode of back pain. The clinical presentation, usually a patient between 20 and 55 years old. Most likely the patient to have an event or incident like lifting a heavy object or pushing a heavy object, sitting on for a long time in good posture, sleeping in a new mattress or somewhere where the patient is not comfortable, so they will have the episode, and sometimes does not have any preceding abnormal or unusual event. May also be gradual onset with aggravation by certain activities and repeated episodes of discomfort. May radiate into buttocks, posterior thigh, or up to thoracolumbar junction, and most likely is associated with back spasm. Patient feeling that their muscle is very tense, and the patient is usually well, and they don't have like a general sickness. They're looking is not generally sick. They usually were looking well, but they have this back pain. So when we assess back pain, we have to be very, specific in knowing what type of back pain. So we can find out the diagnosis and the appropriate treatment. So when you ask about the history, we ask about is the pain worse with sitting or with standing or lying down. Is it better with or worse with walking or activity? Is it relieved when patient is bending forward or bending backward? All these questions will help us to define what's the source of the pain. There is a concept or a definition. It's called mechanical back pain. When we say mechanical back pain, meaning that the patient is sitting or lying down, will not have any significant pain. But once the patient moves, like if the patient stands for a long time, or starting bending, or lifting, or twisting, or turning over the bed, the patient will have pain. But while sitting or lying down, or even standing without significant motion, patient will not have pain. So this is called mechanical back pain, comes from the motion that aggravates the pain. Pain usually that makes it difficult to get to sleep. So at the end of the day, after a long day of work, but not wakes the patient during night, is generally degenerative. Pain that wakes the patient during night is usually not mechanical. So if the patient say, I don't have significant pain while walking, sitting, bending, lifting, it's not really significant. But when I sit down at the end of the day and I start to sleep, this is usually degenerative. And also they will have the pain, also the degenerative pain, they will have some sort of pain in early morning as well, because degeneration causes some sort of inflammation. If the degeneration is in the inflammatory process or phase, they will have also pain in the morning. Also, patients with inflammatory arthritis causing back pain, like rheumatoid arthritis or other inflammatory condition, they will have mainly the pain in early morning. But when you go to the pain that wakes the patient during night, so patient does not have pain during walking or even in early morning, they don't have significant pain, but the pain is worse while patient is sleeping or lying down. This is usually pathological in nature. So the pain has nothing to do with the mechanics. It has to be with some sort of pathology inside the bone, like an infection or a tumor. So that's why when we say night pain is one of the red flags in back pain. So you have to be careful when the patient tells you, I have pain in the middle of the night. Sometimes wakes me up in the middle of the night. So with the back pain, we have some other problems, which is radiation to the lower limbs, and these can be defined or have some types. So we have, the first thing is neurogenic claudication. Neurogenic claudication, we'll talk about it in details, very important. So when we say claudication, meaning that something temporary that comes and goes with certain activity. So the patient is usually do not have back pain or leg pain while sitting. Once the patient stands up and start walking, after a certain period of time or certain distance, they will start to have leg pain. Could be in the calf, could be in the gluteal area or posterior thigh, could be unilateral or bilateral, and the pain gets worse as the patient continue walking. And once the patient sits down for a few minutes, the pain goes away. Then they can stand up again and walk, and the cycle repeats itself. So patients say, if I go from here, if I'm going to walk for like 500 meters, I need to stop 3 times in the way because I have a significant leg pain. I sit for a few minutes on the side of the road or on a chair, then the pain goes away, then I continue walking. This usually comes in elderly patient, and it's because of severe degeneration and arthritis, and causing spinal stenosis. So lumbar spinal stenosis in elderly patient will give us a neurogenic claudication. We'll talk about it more. The other condition or causing the leg pain is radicular pain. So when we say a radiculopathy or sciatica, this means pain going along a single dermatome or a single nerve root. So if the patient have a disc herniation and compressing on, let's say, L5 nerve root, a patient will have pain starting from the back, the buttocks, and going all the way down to the leg, and sometimes to the foot, depending on the nerve it's compressed. So L5 goes all the way to the foot, so the patient will have pain, and this is called a radiculopathy. So radiculopathy, it's compression on a single nerve root, usually unilateral, one side only, left or right. And if the pain is caused by nerve compression, the pain is almost always there. It's not like neurogenic claudication. Neurogenic claudication pains, the pain disappears completely when the patient sits down, but with radicular pain, radiculopathy, the pain, or sciatica, the pain is always there. Patient sitting, standing, walking, sleeping, the pain is always there. There are some conditions that or positions that increases the pain, like sitting down or bending forward will increase the pain, but the pain never goes away. It's usually associated, radicular pain, with a nerve root compression, associated with some effect on that nerve. So patient might have weakness as well on examination or by history, saying I cannot move my leg, or having sensory abnormalities like decreased sensation or numbness along that nerve root. So a single nerve root, so it will be affected the dermatome of that single nerve root and the myotome of that single nerve root, as well as the pain that is associated with radicular pain. When we talk about the radiculopathy, again, as we mentioned, the pain will be referred into the leg following a specific nerve root distribution, can be associated, as we mentioned, with weakness or decreased sensation along that specific nerve root, aggravated by certain movement, but it is always there. They will have positive straight leg raising test on examination, because and the patient, if bend forward, the endobercal المريض, he cannot do that because it will stretch the nerve and have more pain. طبعا the symptoms can be pain, burning or tingling, pins and needles. There will be also aching in the muscles, and might be also associated with numbness and weakness. Neurogenic claudication, as we mentioned before, it is a transient condition, can be characterized by pain, aching, or heaviness in the lower limb, lower back, buttocks, legs, while standing and walking for a certain duration or a period of time. بمعنى انه اول ما يبدا المريض في المشي او الوقوف ما يكون في الم, there is no pain. Once the patient exceed a certain period, 5 minutes, 10 minutes, or يبدا يحس بالالم. طبعا classically they would say calf pain, but it's not only calf pain. Might be or might have only heaviness in the legs. بعضهم ما يحس بألم, just feels that their legs are becoming heavy as they go on, and once they sit down or bend forward, يفتح القناة. لأنه إذا if the patient bend forward or sit down, they will be opening, they will mechanically open the canal. When they sit back or stand up, they will close the canal أو يخلوا تضيق القناة. طبعا هذه also they will have something called positive shopping cart. معنى لو اخذ العربيه حقت السوبر ماركت و امتنع عليها, so bending forward over the shopping cart, they can walk furthermore because they are walking while bending forward. العاده الواحد لما يمشي bend back forward, يمد ظهره على الخلف, فيكون الكمبريشن اعلى على النيرف روت. ولكن لما bend forward they can walk, يعني لو يقول بدون الشوبينج كارت they can walk for 5 minutes, with the shopping cart I can walk for 10 minutes. طبعا في examination usually they don't have any significant weakness. بعضهم they will do examination, so if you ask the patient to walk for 10 minutes, once they feel the pain or feel the heaviness or the weakness in the lower limb, you examine them, you might find out some positive findings. So the pain goes beyond the knee all the way to the leg. It's most likely radicular in nature, meaning having radiculopathy or sciatica, as we mentioned. Differential diagnosis, we have to keep in mind that back pain could be from hip, could be some sort of inflammatory disease, rheumatological disease like ankylosing spondylitis and others. Sacroiliac joint can be a cause of back pain, gastrointestinal, genitourinary, and other significant pathologies. And the back pain could be an infection or a tumor or a fracture in the spine itself, especially in a patient who's having, as we mentioned before, who's having a red flag and might have one of these conditions without clear history, like an elderly lady might have a fracture without any trauma. So we always have to check the red flags when we take history of back pain, as we mentioned, general red flags and specific red flags for back. And we all went through that. There's like a classifications called the yellow flags. This is if the patient is having either malingering or having like a psychological problem that reflect their behavior and might tell them that they have severe back pain with no true pathology in the back. So they might be requiring like relief from their job or behaving that they are very sick, or if they are having depression. All these things might be or called yellow flags. So you have to keep in mind for these yellow flags that you don't miss them. So if the patient, let's say simply, if the patient tells you I have back pain and at the end they want like sick leave or they want drugs, like some patients who are addicted to painkillers, so it might be the condition. Now we'll talk a bit about degeneration in the back. So degeneration means deterioration of tissue and organ which its function is diminished or its structure is impaired. So it's some sort of natural history or a normal process that happens with aging. There will be deterioration in function like in any part of the body. We call it degeneration or significant degeneration once the function is affected. So you might see some degeneration on an MRI, let's say, but it's not causing any problem for the patient. So we call it non-significant degeneration. But if it starts to become more severe, more symptomatic, and causing problem like spinal stenosis or deformity or instability, we call it significant degeneration. In the spine, they call it spondylosis, but it is the same as degeneration. In the spine, we have two main joints, and degeneration and arthritis happens, as you all know, in joints, not in bone. It might happen in the disc itself, so degeneration of the disc, or arthritis or degeneration in the facet joint. Facet joints are small joints in the back or the posterior part of the spine and might get arthritis. Usually, in general, in all the joints in the body, degeneration is multifactorial. Definitely age, as the patient goes older, degeneration becomes more common, but it has other factors like genetics, environmental factors like smoking, obesity, previous injury, deformity, and some work as operating a heavy machinery, repetitive standing, repetitive jumping. All these might increase the incidence of degeneration, but eventually everybody gets degeneration. But the question is how early you get it and how symptomatic is the degeneration or the arthritis. So if we do an MRI of like an 80-year-old man without any back pain, they will have significant degeneration because of age, but might not be symptomatic because it's not so severe, and the patient general condition, muscles, strength, and all these things will prevent him from having any symptoms. So natural history, as I mentioned, disc degeneration starts with it goes into stages until it becomes complete collapse of the disc and bone on bone, and so on. This is when we have degeneration in the disc, we start to have, as you can see here, the sequelae. So disc space collapse, facet joint hypertrophy، لأن يصير في ضغط على الجوينت at the back لأنه ارتفاع الديسك الطبيعي مختلف. بعدين يصير في soft tissue unfolding، في هنا something called ligamentum flavum. Ligamentum flavum هو أحد الليجمنتس اللي موجودة في posterior spine. Once you have collapse in the disc and arthritis in the facet joint, loss of height of the disc, they become enfolded. يصير لها يعني enfolding, and they start to cause narrowing in the spinal canal. And you look here, this is the normal spinal canal. هذا طبعا this is a cross section looking at the patient from the top. هنا الديسك في الأمام وهذا spinal canal. النقط السود هذه النيرفز، الأبيض هذا CSF الساعة اللي تسبح فيه النيرفز، وهنا البوستيريور، والأسود هذا هو الليجمنتم فلافم. As we go here, more degeneration. هذا الفاسد جوينت يصير فيه arthritis، ويصير فيه thickening وانفولدنج للليجمنتم فلافم، هذا اللي موجود هنا. تشوف CSF مكانه قل فنسميه mild spinal stenosis، وهذا severe spinal stenosis. You can see there is almost no CSF can be appreciated, only the nerves. مقارنة هذا مع هذا. In this condition, if you have spinal stenosis, patient will have neurogenic claudication. And also another picture of disc degeneration and collapse. Normal, then it becomes black disc, we call it, and loss of the watery matter inside the disc. Then it starts to get more collapse. طيب الديسك اللي تكلمنا عنه اللي له علاقه كبيره بالباك بين، والديسك ديجنريشن كان كوز باك بين از ويل. فزي ما ذكرنا انه يحصل عندهم degeneration. والفيرست stage of degeneration is loss of the gelatinous matter or the watery matter, which is called the nucleus bulbosus. فيصير عندهم loss of hydration, what we call it black disc, as we showed you previously. And once the patient have black disc, the motion and the flexibility of the back start to decrease, and this might cause back pain. Also with the disc degeneration, what we have loss of disc height, as we showed you before. لما يكون في loss of height تختلف البايوميكانكس of the back، يصير abnormal loading على الفاسد joint و increase اللود على الفاسد joints. And you might have stenosis, spinal stenosis. بعدين يحصل عندك bulging of the disc لأنه منضغط من الأمام، ويصير عنده again spinal stenosis. ممكن يحصل عندنا true disc herniation. طبعا degeneration has nothing to do with disc herniation. Disc herniation انزلاق ظروفي actually happens in young patient in a healthy disc، بس يحصل في tear في outer layer وتطلع النيوكليوس اللي هي inner gelatinous matter and compress on the nerve and causing radiculopathy or sciatica and lumbar spine. Facet joint, as you mentioned, the posterior, as we mentioned, is the posterior joints, small joints in the back. It is a synovial joint. With the disc, they form the three joints, as we mentioned. The disc and the two facets are the motion segment in the back. Mainly, they're loaded in extension. But if the patient has more pain, more back pain with extension, لما يوقف يمد ظهره للخلف, this is most likely because of facet arthritis. But if the patient has pain while leaning forward, زي لما يكون جالس يمد على تحت, this is most likely discogenic in nature. هذه برضه التفريق extension, standing and extension. If the patient has pain, this is most likely because of the facet. If the pain is worse with flexion and sitting, it is most likely discogenic in nature. With any degeneration or arthritis, we have hypertrophy, osteophyte formation, and this is because we have a very narrow space. This might also contribute to spinal stenosis. في الادفانس ستيجز يحصل عنده laxity في الفاسد جوينت، يصير فيه instability لأن الكبسول مع الارثرايتس تخرب الكبسول فتصير more lax وما في stability في الجوينت and might lead to degeneration or spondylolisthesis اللي هو زي ما شرحنا أول، بس هذه degenerative spondylolisthesis معناته instability في السباين. زي ما قلنا نرجع again, back pain is very important. So the mechanical pain usually due to degeneration or instability, activity related not present at rest. يعني المريض وهو مرتاح أخذ وضعية معينة جالس أو نايم, there is no pain, only pain with specific movement, bending, twisting, lifting. وزي ما ذكرنا النيوروجينيك component, neurogenic claudication or radiculopathy، أو في حاجة يعني إذا كان عندنا الكمبريشن above L1 يصير في compression على السباينال كورد. لما يكون تحت السباينال كورد تحت L1 ديسك L1 L2 يصير عندنا يا radiculopathy يا neurogenic claudication أو spinal stenosis. أما إذا كان الكمبريشن على الكورد ليفل يعطينا condition called myelopathy. condition called myelopathy. والميلوباثي هذه معناتها إنه في compression على spinal cord غير الكمبريشن اللي يحصل مع التروما. يعني مو بأنه صار حادث وصار إصابة للحبل الشوكي، لا، هذا degenerative مع وقت خلال أشهر أو حتى سنوات يصير فيه compression على السباينال كورد ويعطينا condition called myelopathy. ما هي myopathy هذه pathology in the muscles. This is myelopathy, which is pathology in the spinal cord. زي ما قلنا mechanical pain. discogenic يحصل زي ما ذكرنا while ايش؟ sitting and leaning forward, you will have the discogenic pain. If you have the pain while extension and standing, this is facet syndrome or facet pain or flexion discogenic pain. نرجع لهذه النقطة مهمة جدا، نرجع لها أسئلة كثير. spinal cord compression progressive compression ما هو acute زي spinal cord injury. spinal cord injury هذا يحصل في إيش؟ في acute injury زي تروما، طيحة أو شيء، ممكن يكون complete or incomplete. هذه we talked about this is spinal cord injury. أما ال condition which is called myelopathy هذه تجي progressive، يعني كان عنده degeneration أو discarnation شوي شوي حصل فيه compression على spinal cord، يعني compression above the level of L1 زي ما قلنا. spinal cord ينتهي L1، فإذا حصل خصوصا في السيرفايكل، مثلا لو كان في السيرفايكل سباين في degeneration شوي شوي حصل فيه compression على spinal cord يعطينا condition called myelopathy. Patient present with loss of motor power and balance. ما هو يعني severe weakness ولكن ما عندهم balance. They cannot control their hands. Loss of dexterity in the hand، يعني الحركات البسيطة في الهاندز زي الأشياء تطيح من اليد، إذا يبغى يمسك مثلا سكينة أو شوكة بيقطع ما يقدر، يبغى يكتب خطه يختلف كثير، صعوبة مثلا يمسك إبرة من فوق طاولة، يسك زرار الثوب. هذه لما تجي when you examine the patient their power is not bad، يعني usually it's not severe weakness ولكن their coordination is lost. برضو يجي معاها الجيت، they will have يعني imbalance in the gait، they can fall. كل هذه طبعا والاكزامينيشن يصير عندهم upper motor neuron lesion، يصير عندهم hyper reflexia، يصير عندهم rigidity، positive Babinski، positive clonus، وهذه كلها تحصل في الحالة اللي نسميها upper motor neuron lesion اللي هي called myelopathy. ممكن تكون في السيرفايكال سباين، ممكن تكون في الثوراسيك سباين، ولكن لا يمكن أن تكون في اللمبر سباين لأنه ما في سباينال كورد في اللمبر سباين. واضح؟ هي mainly تحصل على الكورد ليفل، progressive compression على spinal cord usually in the cervical spine. Patient come or present with loss of hand function and loss of their stability. They say they report multiple falls in the last few months, and you find out when you examine the patient they will have upper motor neuron lesion زي ما ذكرنا اللي هي rigidity والhyperreflexia والpositive Babinski والpositive clonus، كلها تحصل معهم ويصير عندهم myelopathy. طبعا زي ارجع واقول يختلف تماما عن ما هو اللي هو السباينال كورد انجري. كودا ايكوانا تكلمنا عنها طبعا بتفاصيلها، تكون acutely، اما اذا كان progressive يكون neurogenic claudication. We have to differentiate between vascular and neurogenic claudication. طبعا discarnation might happen and radiculopathy، عشان بس تفرقون radiculopathy can happen in the cervical spine, thoracic spine and lumbar spine. كلها إذا كان الديسك على السايد ما هو ضاغط على السنتر، ما هو ضاغط على spinal cord might give us neurogenic radiculopathy. طبعا يعطينا radiculopathy. أما إذا كان الcompression central على الspinal cord يعطينا الميلوباثي. The management we will not talk about it. This is just few pictures that you can appreciate. This is the normal disc. This is the degenerative disc or arthritic disc. This is because of severe arthritis, patient is having instability. You can see scoliosis and lateral listhesis. This is the management. So just wanted to see. So here is another picture showing the spinal stenosis. زي ما قلنا مع الوقت ويحصل فيه arthritis في الفاسد joints وhypertrophy of the ligamentum flavum وcompression على السنترال canal بالمقارنة مع النورمال nerves. أما في حالة disc herniation, it's an acute condition. In young patient, they will have disc herniation compressing on one nerve root, as you can see here, causing radiculopathy. واضح؟ هناك جاي المنطقة كلها arthritic وتايت. هنا لا، يجي single nerve root compressing on a single nerve root. هنا this is the right nerve root, it's normal. This is the left nerve root. You can see the disc compressing on that and causing radiculopathy. Okay. So disc herniation. What is disc herniation? طبعا زي ما انتم عارفين الديسك يتكون من طبقة خارجية اللي هي الانيولس strong fibrous layer، ويتكون من طبقة داخلية اللي هي ايش؟ اللي هي الوايت اللي هي النيوكليوس اللي هي gelatinous matter. طبعا with multifactorial problems يحصل فيه تير في الاوتر layer اللي هي الانيولس مع repetitive pressure. طبعا multifactorial ممكن يكون family history or genetic predisposition, smoking, obesity, weak muscles, repetitive compression زي ما قلنا واحد يشتغل على تراكتر او all day jumping. كل هذه will cause some tear or weakness in the outer layer. بعدين يطلع لما يصير في تير يطلع جزء من الانيولس اللي هي الداخليه النيوكليوس عفوا الجيلاتينس ماتر تطلع و it compresses on usually on a single nerve root. اذا طلع كامل وضغط على كل النيرفز يعطينا كودا ايكوينا، بس اذا طلع جزء واحد وضغط على single nerve root يعطينا sciatica or radiculopathy. وهذا هو تعريف disc herniation. Usually 95% of patients within 3 months the pain goes away. كيف يروح البين؟ إنه the body will take care of this and يصير له resorption and the pain goes away within 2 to 3 months. طبعا 90 to 95% of patients will have no sciatica. وهذا طبعا ممكن يحصل في السيرفايكال سباين وممكن يحصل في اللمبر سباين وممكن يحصل في الثوراسيك سباين. اذا كان مثلا في السيرفايكال سباين اذا كان الكمبريشن على السايد زي كذا يعطينا ريديكولوباثي، اما اذا كان سنترال يعطينا مايلوباثي. واضح؟ مايلوباثي. اما في اللمبر سباين اذا كان سنترال يعطينا كودا ايكوين. اوكي. Any questions? Any questions? طيب 5 دقائق ونرجع على السكند lecture. We'll talk about the bone tumors.